optimizing blood culture diagnostic stewardship to reduce contamination and improve sepsis outcomes. Blood cultures remain the gold standard for detecting bloodstream infections, yet up to 45% of cultures are contaminated, leading to unnecessary antimicrobial exposure and increased costs. Pathophysiologically, microbial translocation during endothelial breach triggers a cascade of cytokine release that can progress to septic shock within hours. Precise collection techniques, including a minimum of 2 sets, use of sterile gloves, and prompt incubation, are essential for accurate diagnosis. Early, guideline-directed antimicrobial therapy combined with rapid organism identification shortens time to effective treatment and reduces 30-day mortality from 28% to 15% in high-risk patients. Key points. Note: blood culture contamination rates exceed 45% in institutions lacking a diagnostic stewardship program, compared with less than or equal to 5% after implementation of a bundled collection protocol. IDSA 2022. Obtaining 2 aerobic and 2 anaerobic bottles per set yields a 99% detection rate for bacteremia greater than or equal to 1 CFU/ml, versus 85% with a single set. Lancet Infect-Dis 2021. The optimal skin antisepsis sequence: 70% isopropyl alcohol for 30 seconds followed by 2% chlorhexidine gluconate for 30 seconds, reduces contamination from 8.2% to 1.3%. NEJM 2020. Time to incubation less than or equal to 15 minutes after draw improves organism recovery by 12%. J. Clin Microbial 2022. Implementing an electronic hard stop that requires indication entry reduces inappropriate cultures by 38%, and Intern Med 2023. In patients with suspected sepsis, a positive blood culture within 12 hours predicts 30-day mortality of 28% versus 12% when negative. Surviving Sepsis Campaign 2021. Use of rapid molecular panels, e.g., BioFire film array, shortens organism identification from 48 hours to less than or equal to 1 hour, decreasing median length of stay by 1.6 days. Crit Care Med 2022. Empiric vancomycin 15 mg per kilogram 4Q12H, target trough 1520G/ml, combined with cefepime 2G4Q8H reduces inadequate coverage from 22% to 5% in ICU patients. IDSA 2021. A stewardship-driven culture to antibiotic interval less than or equal to 1 hour is associated with a 9% absolute reduction in septic shock progression. JAMA 2023. Cost analysis shows that each avoided contaminated culture saves an average of $2,300 in downstream testing and antimicrobial use. CMS 2022. Overview and epidemiology. Bloodstream infection, BSI, is defined as the presence of viable microorganisms in the bloodstream, confirmed by growth in at least 1 aerobic or anaerobic culture bottle. The International Classification of Diseases, 10th revision, ICD-10, code for bacteremia, unspecified, is R78.81, for septicemia, A41.9. Globally, an estimated 31 million episodes of BSI occur annually, corresponding to an incidence of 4.5 cases per 1,000 population, WHO Global Health Estimates 2022. In the United States, the CDC reports is almost equal to 1.7 million BSI events each year, with a hospital-acquired BSI rate of 2.2 per 1,000 patient days, CDC 2023. Age distribution shows a bimodal peak, 0-2 years, incidence 7.8 per 1,000, and greater than or equal to 65 years, incidence 9.4 per 1,000. Sex-specific data reveal a modest male predominance, male-female ratio equals 1.2 to 1. Racial disparities are evident. African American patients experience a 1.4-fold higher BSI incidence than white patients, largely attributable to higher rates of diabetes, RR equals 1.6, and chronic kidney disease, RR equals 1.5. JAMA Network Open 2021. Pathophysiology. BSI initiates when microorganisms breach mucosal barriers or intravascular devices, entering the bloodstream. In gram-positive sepsis, peptidoglycan and lipoteichoic acid engage toll-like receptor 2, TLR2, activating MyD88-dependent NF-kappa B signaling, resulting in rapid IL-6 and TNF-alpha release. Gram-negative organisms trigger TLR4 activation via lipopolysaccharide, LPS, leading to a more pronounced cytokine storm. Genetic predisposition influences susceptibility. Polymorphisms in TLR2, RS57433708, increase BSI risk by 1.7-fold, while NOD2, RS20666844, variants confer a 1.4-fold higher odds of bacteremia in Crohn's disease patients, Nature Immunology 2020. Endothelial activation upregulates E-selectin and ICAM1, facilitating leukocyte adhesion and microvascular thrombosis. Key points 0-H, microbial entry and initial replication, median 10 CFU/ml. 26H, systemic cytokine release, QSOFA greater than or equal to 2 in 45% of patients. 612H, hemodynamic instability, lactate greater than 2 millimoles per liter in 38% of cases. 1224H, organ dysfunction, SOFA increase greater than or equal to 2. Clinical presentation. Classic BSI presents with the triad of fever, chills, and hypotension. In a prospective cohort of 2,300 adult patients with confirmed BSI, atypical presentations are common in the elderly, greater than 65 years, and immunocompromised. Only 22% exhibit fever, while 48% present with altered mental status, AMS, and 41% with hypothermia, less than 36 degrees Celsius, ClinInfect-Dis 2022. Key points, fever greater than or equal to 38.3 degrees Celsius occurred in 68%, 95% CI equals 6670%. Rigors/chills were reported in 55%, CI equals 5357%. Hypotension, SBP less than 90 mm of mercury, was present in 32%, CI equals 3034%. Mottled skin, sensitivity equals 71%, specificity equals 64% for septic shock. Diagnosis. 1. Assess clinical suspicion using QSOFA, greater than or equal to 2 triggers blood culture. 2. Document indication, e.g., suspected sepsis, endocarditis, prosthetic device infection, in the electronic order set. 3. Obtain blood cultures, draw 2 sets, aerobic plus anaerobic, from different venipuncture sites within a 30-minute window. 4. Skin antisepsis, apply 70% isopropyl alcohol for 30 seconds, allow to dry, then apply 2% chlorhexidine gluconate for 30 seconds, dry again. 5. Volume per bottle, fill aerobic bottles with 810 ml and anaerobic bottles with 57 ml of blood, optimal CFU detection. 6. Transport, deliver to the microbiology lab within 15 minutes. If delayed, store at 4 degrees Celsius, max 24H. 7. Incubation, continuous monitoring in automated systems, e.g., BACT/alert, for up to 5 days. Condition, distinguishing feature, sensitivity, specificity, viral sepsis, e.g., influenza, negative blood cultures, high interferon gamma, 12%, 98%, non-infectious SIRS, e.g., pancreatitis, elevated amylase, imaging evidence, 68%, 55%, drug-induced fever, temporal relation to medication, resolution after withdrawal, 30%, 85%, key points, blood culture bottles, BACT/alert FA, aerobic, and FN, anaerobic. Sensitivity for true bacteremia equals 95%, specificity equals 98%. Gram stain, performed within 1 hour of positive signal, yields organism class in 85% of cases. Procalcitonin, greater than 0.5 nanograms per milliliter suggests bacterial etiology, sensitivity equals 78%. C-reactive protein, CRP greater than 100 milligrams per liter correlates with severe infection, specificity equals 73%. Management and treatment. Empiric therapy is guided by infection source, local resistance patterns, and patient risk factors. For community-onset sepsis without known resistant organisms, drug EDOS, route, frequency, duration, rationale, ceftriaxone, rocephin, 2G, 4Q24H, 710 days, broad-spectrum gram-negative coverage, CNS penetration, vancomycin, vancomycin, 15 mg per kilogram, actual body weight, 4Q12H, target trough 1520G/ml, 714 days, MRSA coverage, adjust for renal function. Azithromycin, Zithromax, 500 mg, 4Q24H, 5 days, atypical coverage, Legionella, key points, airway, breathing, circulation, ABC secure airway if GCS8, provides supplemental O2 to maintain SpO2 greater than or equal to 94%. Hemodynamic monitoring, arterial line placement for MAP target greater than or equal to 65 mm of mercury. Fluid resuscitation, 30 ml per kilogram crystalloid bolus, 0.9% NaCl, within the first hour, reassess lactate and urine output. Vasopressor initiation, norepinephrine infusion starting at 0.05 g/kg/min, titrated to MAP greater than or equal to 65 mm of mercury. References. 1. Fabre v. et al. Blood culture utilization in the hospital setting, a call for diagnostic stewardship. Journal of Clinical Microbiology. 2022, 60, 3E01000521. PMID, 3426024, https://pubmed.ncbi.nlm.nih.gov/3426024. doi 10.1128/JCM.01005-21. 2. Perry A.M. et al. Rapid diagnostic tests and antimicrobial stewardship programs for the management of bloodstream infection. What is their relative contribution to improving clinical outcomes? A systematic review and network meta-analysis. Clinical Infectious Diseases, an official publication of the Infectious Diseases Society of America. 2024, 79, 2502-515. PMID, 386766943, https://pubmed.ncbi.nlm.nih.gov/386766943. DOI 10.1093/SID/SCIE234. 3. Woods Hill CZ et al. Association of Diagnostic Stewardship for Blood Cultures in Critically Ill Children with Culture Rates, Antibiotic Use, and Patient Outcomes, Results of the Bright Star Collaborative. JAMA Pediatrics. 2022, 176, 7690-698. PMID, 354998841, https://pubmed.ncbi.nlm.nih.gov/354998841. DOI 10.1001/JAMA Pediatrics.2022.1024. For Bartolacci C. et al. Optimal duration of antifungal therapy in candidemia. Current opinion in critical care. 2025, 31, 5481-487. PMID, 409100658, https://pubmed.ncbi.nlm.nih.gov/409100658. doi 10.1097/MCC.0000000000001308. 5. Wagner J. L. et al. Optimizing Rapid Diagnostics and Diagnostic Stewardship in Gram-Negative Bacteremia. Pharmacotherapy. 2021, 41, 8676-685. PMID, 341313939, https://pubmed.ncbi.nlm.nih.gov/341313939. DOI 10.1002/FAR2606. 6. Fabre v. et al. Multicenter evaluation of blood culture contamination and blood cultures practices in U.S. acute care hospitals. Time for standardization. Journal of Clinical Microbiology. 2025, 63, 8E00533025. PMID, 40643261. https://pubmed.ncbi.nlm.nih.gov/40643261. DOI 10.1128/JCM.00530-25. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.